So it really is my pleasure to introduce someone who really needs no introduction here, but Bob Canter, who is a great example of someone who has done the hard work of trying to combine a basic science career with a clinical career, but the tremendous pleasure that comes from sort of taking things from bench to bedside and back together, I think he really exemplifies more than most here, and we're really fortunate to have him continue to sort of lead the path on the basic science part of our research endeavor, and really appreciate it. So,
great. Thank you very much for the introduction. So these are my disclosures. I don't miss any opportunity, as you know, who work with me. This is Charlotte, my daughter, who's the oldest, Graham, and Teddy. And that's why I didn't finish the talk until about 7:18 this morning. So some objectives for this talk, which I hopefully will go through with you and leave you with some pearls, is what is immunotherapy? Why is immunotherapy important? What are some of the basics of tumor immunology that have allowed us to really make some recent leaps that are transformative in cancer treatment and cancer science? And what are the two real success stories of this, which are immune checkpoint inhibitors, which are monoclonal antibodies, and CAR T cells, which are a form of adoptive cell transfer? And then what is the future of immunotherapy, including combination therapies and maybe novel agents? So, why should you care? The so what aspect of this. Many of you are involved in cancer clinical care, and obviously that's relevant to you if you treat cancer patients. Many of you, in fact, most of you will probably be touched by cancer, either personally or with family and friends at some point in your life. And cancer still really holds a very visceral effect on us and our society, even today. And it's really sort of a scourge of modern society in many ways, more so than many other diseases, perhaps. It's been called the TB of the 20th century. It has this very, evokes a lot of fear because it sort of consumes you from the inside out. It's chronic, it's unrelenting. And until recently, there was really a lack of treatment options aside from sort of historical treatment like surgery, which dates back over 100 years. And as I said, it's still a significant problem in the U.S., even though we're doing better. There's about 12 million cancer survivors who are alive in the United States. Approximately 1 in 3 women are going to be diagnosed with cancer at some point in their life. 1 in 2 men, and that's in the U.S. And then it's the second leading cause of cancer deaths in the United States. 25% of cancer deaths are from cancer in the U.S. and 15% worldwide. So it's an important problem. And again, it may touch you at some point in your life. So I think it's obviously potentially relevant to you as physicians and as people. And then also what I think it's a very interesting story. It's pretty cool stuff. There's likely going to be several Nobel Prizes in the coming years as related to advances in cancer immunotherapy. And it's really sort of illustrates the proof in principle that, first of all, you can get rid of massive amounts of cancer with immunotherapy, which is really otherwise unheard of with other treatments. And it's really sort of a clarion call for what science can do. And that's why cancer immunotherapy has really hit the stage. It's been transformative. Like I said, science called it the breakthrough of the year. I think this was 2013. And it's really appealed to the popular imagination because it's sort of harnessing the body's own physiology, own defense system to try and fight back against cancer, which, as I said, has this very visceral fear. And it sort of evokes a famous quote of St. Thomas Aquinas. Dr. Holcroft will appreciate this, being the Renaissance man that he is. St. Thomas Aquinas was a sort of medieval clergyman, philosopher, theologian who said the more perfect a power it is, the more difficult it is to quell. And that really kind of summarizes, encapsulates cancer and perhaps why immunotherapy really, like I said, has such an appeal as a treatment. there's one slide or one point I want you to remember from today, it's this one. And this is why immunotherapy really is a big deal and not just hype. And that is these so-called tails. Okay, this is a Kaplan-Meier curve. For those of you who are not familiar with Kaplan-Meier curve, you can't give a cancer talk without showing at least one Kaplan-Meier curve. All right, this is the event, usually survival. It could be any event. This is time, so this is what we call a time-dependent analysis, sort of the probability of an event occurring over time. And what these tails signify is people who never have an event. They're cancer-free. They're long-term survivors. They're cured. Okay, again, really, aside from local therapies like surgery, the medical therapy of cancer really has been more about this. It's about pushing this curve to the right rather than really changing the overall ultimate outcome. So these are cures with cancer, with immunotherapy. And cure means they will not die of cancer, which is really, like I said, very transformative. Okay? And this is in contrast to 100 years of advances with cancer chemotherapy, with systemic therapy. There's some notable exceptions with targeted therapy. But in general, you're talking about delaying progression rather than really making substantial cures. All right? This is one of the most egregious examples of what's considered an advance. This is erlotinib for pancreatic cancer. This is a 10-day improvement in survival, so 0.3 months, it's about 10 days. Statistically significant. This was approved by the FDA based on these data. But, you know, again, very, very modest incremental benefits at best. So that's the distinction, sort of the counterpoint with immunotherapy and why it's important. All right, this is a curve from a recent trial with melanoma with nivolumab, a PD-1 inhibitor, which I'll explain to you. Granted, the follow-up is relatively short, but you're already starting to see this tail emerge, this people who are long-term responders, potential cures from the treatment. All right, and this is why there's really been an explosion of new approvals and in new cancers with immunotherapy in the last 5 years predominantly. And previously, immunotherapy had a relatively unimpressive, ambiguous record, but these are all fairly unequivocal. And in cancers which previously were thought to be resistant to immunotherapy, like lung cancer, bladder cancer, etc. So it's really across the board, all right? And these are predominantly with what do we call checkpoint inhibitors, again, which we'll get into a little bit. All right, just a little break up the slides. This is vacation with my son, who still likes to get up at 5 o'clock in the morning on vacation. So, what is the history of immunotherapy? Like I said, prior immunotherapy overall was fairly ineffective. It was fairly unreproducible. There were reports of dramatic cures or dramatic responses with immunotherapy which couldn't be reproduced or couldn't be translated into other situations. And so, the popular wisdom was that tumors were too smart or too similar to self to really be targeted with immunotherapy. One of the principles of immunology is the ability for the immune system to really recognize the difference between self and non-self and to avoid autoimmunity while also being able to fight off foreign invaders. So really, cancer immunotherapy was a backwater until about 2005. And Jim Allison, who was the inventor of the CTLA-4 inhibitor, and who will probably win a Nobel Prize for inventing ipilimumab, really reports sort of being, pushed aside and somewhat scoffed at cancer meetings because he was interested in immunotherapy, and times have obviously changed quite a bit. All right. So, why has this been so challenging, and why have advances been so slow? Is really the immune system is just highly complex. It really plays a very dangerous game. It has to protect you and self from foreign invaders. It has to be able to recognize them. It has to be able to target them. It has to be able to kill them very effectively. But it also has to avoid attack on self and self tissues because the effects of that can be autoimmunity, which can be very severe. It can be collateral damage. And if you look at the great pandemic of influenza in 1918, what's interesting about that is when there was, millions of people who died worldwide from influenza. It was actually the younger 20 to 40-year-olds who were, had the highest death rate, and there's evidence that it was because of over-exuberant response of the immune system. So the response to the flu or to the invader was excessive, causing more damage than the actual insult itself. So it's really a very complicated and delicate balance, all right? And this, I won't get into all this, but this just is one example of how complicated the immune system is and how the ability for the immune system to regulate itself is so complex. And these are all the different cell types. There's proteins and antibodies. There's cytokines. They're all in a very complicated interplay to be able to deal with different foreign insults and pathogens. All right, and this has led to sort of some of the laws of immunology, the 3 laws of immunology. Number 1, the universality, the ability to recognize an unlimited or nearly unlimited set of antigens or amino acid sequences. And this gets into genetic rearrangement at the level of antibody and the TCR receptor, so that you have these highly complicated rearrangements that can give rise to billions and billions, trillions of different possible combinations to potentially recognize any possible foreign antigen. All right, but then you have to have the ability to eliminate the ones that recognize self or respond to self, and this is called tolerance. And this is very important, as I said, to avoid autoimmunity, which can sometimes be worse than the actual pathogen that you're exposed to. And then finally, related to this is the appropriateness, or the ability to control or tune the response to deal with the invading pathogen, but also shut it off or avoid over response. All right, and that's why it's such a delicate balance between attack and shutting it off. All right, and you need all of these things to be able to do it effectively: specificity, speed, memory, the ability to evolve, and control and regulation. All right, and this is why, as I said, it's so complex. This is one of sort of the fundamental ways that the body recognizes and responds to antigen. This may ring a few bells in medical school and Janeway immunology. We're focusing here on T cells and the T cell receptor, because it's critical to immunotherapy, but this also happens with antibodies and antigen recognition, et cetera, in B cells. So you have a TCR, T cell receptor, which, as I said, has been created. Each T cell in general has a different one. It's been created by genetic rearrangement at the chromosomal level. It can recognize a specific peptide. And this peptide gets presented by MHC1 in the case of a CD8 cell, which is a killer cell. It gets presented by MHC2 by an antigen-presenting cell in the case of CD4 or CD4 helper cells. And this has to be a very specific binding. Okay, and that's signal 1. That's really just the first step to create a response. Is a MHC TCR binding or interaction. That's signal 1. That then has to receive a signal 2, or a co-stimulation. In the absence of co-stimulation or subsequent stimulation, this cell becomes anergic or becomes deleted because it doesn't have appropriate co-stimulation. And this is where the regulation becomes very important and very interesting. So the co-stimulation is then from this interaction between CD80 or CD86 on the antigen-presenting cell or on the target cell and CD28, which is on the T cell. Now what's interesting is when you can come back, this can be shut off by a negative co-stimulation, which is what CTLA-4 is. And we'll talk about CTLA-4 in a little bit. And what's even more interesting is that the binding of CTLA-4 to CT80 or CD86 is stronger than the binding to CD28. And this, like I said, illustrates a very important principle, that negative signals or off signals are often stronger, or usually stronger, than on signals, because the body wants to have this ability to shut things off in a more tightly controlled fashion than turning them on. And that's signal 2, and then you need a signal 3, which is cytokine secretion and crosstalk between the two cells to amplify it and lead to greater activation and greater expansion of that T cell. All right, so this is sort of the rudimentary way of explaining this, but has value, is that the signal one is the specific of putting the specific interaction, allowing the keys to go into the ignition, to actually have a specific effect there, turning on the car. And then you have your gas pedal, which is co-stimulation, and then you have your signal 3, which is your donuts and coffee to really kind of get you going, all right? And this, once you have all these, then you're allowed, or you're enabled, the T cells are enabled to actually go after an invader and take care of them, all right? But then once that's been effective, you then have to have additional breaks to turn it off and to shut it down, okay? And this is kind of a very useful way of thinking about it in terms of the gas pedal and the brakes. And these are all operative in the immune system to deal with primarily microorganisms, but also cancer. So as I said, historically, immunotherapy hasn't been very effective. Why is that? Why doesn't the immune system do a better job of recognizing cancer? One of the things is that negative or off signals in immunology tend to be stronger than positive or on signals. But there really is evidence that the immune system does recognize cancer. And this whole concept of immune surveillance dates back to the 1960s, that there is an intrinsic level of surveillance going on by the host to try and recognize and eradicate any cancer cells. But this is, sorry, these are my kids when we went to buy glasses. They're playing around. So why is that? So let me take a step back. Why isn't the immune system better able to deal with cancer? And then I think, as we'll talk a little bit about it, it does to some degree, although not as its primary role. But in part because the epidemiology of cancer is changing. Now, cancer has been around historically in human populations. It's been recognized anthropologically, probably in osteosarcoma. It's been recognized in texts from Egyptian civilizations, Greek civilizations, etc. So it's been around, but it's probably not been a primary source of mortality for humans historically. And there's probably reasons for that. Changing longevity. Cancer is primarily a disease of the aged. Changing environment, exposure to toxins and carcinogens, and eradication of infectious diseases, which are all sort of issues which have affected why cancer is more prevalent and more lethal than it was previously. But that being said, the immune system has evolved to deal with cancer because cancer historically has been a source of evolutionary pressure. And this is sort of dramatized in what we call the immunoediting hypothesis, okay? And this is probably another important concept that, if you're going to walk away with anything from this talk, it would be this, okay? So cancer really is a disease of the genes, and it's really evolution or Darwinian selection at the cellular level. So these cancer cells start growing out of control, and their whole objective is just to keep growing and keep dividing, even though it can lead to the death of the host, okay? So what happens is you have these immune cells that are there to try and prevent that from happening. And so really, immune surveillance and immune recognition really happens at the very early stage, where you have elimination, where you have recognition of clones that are malignant, and they're eliminated. And the cells that do this are here, but suffice to say that there really is evidence that this happens. But the sort of paradox of this is because you are having elimination of malignant cells, you're having selection pressure on those cells to evolve ways to evade the immune system. And that leads to this whole concept of immune evasion. So by trying to attack cancer cells through the immune system is also, in a way, leading to the outgrowth of cancer cells which can evade the immune system and subsequently go on to progress and spread and be lethal, as I said. And this is sort of the three stages: elimination, progressing to equilibrium, where things are at a balance, a homeostasis, progressing to immune escape, where the host immune system is no longer able to deal with cancer, and that's when we see it clinically and we see it macroscopically. And so you really don't see it at this level. And so that's why it's always has been somewhat controversial, because you only see it at this level. This level is harder to find evidence of, so people assume that it didn't happen. But, I won't go into all the data that does support that this does happen. And this will probably be another Nobel Prize, is this whole concept of immunoediting and how the tumors, the sort of seed and soil, how tumors sculpt the immune system and how the immune system sculpts tumors. All right? And we do know that lymphocytes will infiltrate tumors. And we see this in melanoma, we see this in other cancers, and there are studies showing that these tumor-infiltrating lymphocytes are clinically relevant. They affect prognosis. Tumors that have tumor-infiltrating lymphocytes tend to have a better prognosis. But again, the paradox is it's not enough, because by itself it's inadequate. All right? So, why is that, and why has immunotherapy been previously ineffective? This is William Coley. He was a surgeon in New York in the early 1900s, and he was one of the first pioneers of immunotherapy. And he made an observation that patients who had this very virulent strep infection called erysipelas could often, if they had cancer, it would often cause their cancer to completely disappear. So he then pioneered these injections called Coley's toxins, where he took basically bacteria. It's unclear if it was live or dead or a combination, and he would inject patients with bacteria. This obviously has a long and sordid history. We know it very well at this institution. But it was associated with dramatic cures in a few cases. He had publications, he gave lectures, but the problem was it was too random or unpredictable as to who would respond and who wouldn't. And it was subsequently very difficult to reproduce. So it was kind of abandoned as chemotherapy became developed, as radiation therapy became developed, as other treatments for cancer became developed and seemed to be better able to be controlled and studied and predicted. But likely this was the precursor to TNF, which for those of you in cancer therapy are familiar with, and those of you who are in other diseases, it's part of cancer, cachexia, and so forth. So he was on to something, but his tools and methods were very primitive. All right? But we know now that cancer immunotherapy does work and can be dramatically effective. This is a case report from the New England Journal of Medicine. This is a big melanoma metastasis on the chest wall. You can see it right here. And the patient got one cycle of checkpoint blockade, and it totally disappeared. Complete necrosis and disappearance. So it is very effective, and it can be, much in the same way probably Coley's toxins were. But now we understand the science better. Okay? So a brief overview of tumor immunology, because it relates to kind of what's been effective and what's been ineffective. So you can think about this as a tumor full of tumor cells, and some of these tumor cells die for whatever reason. They're hypoxic, they outstrip their blood supply, they're exposed to radiation, what have you, and this releases tumor antigens. And these antigens get taken up by dendritic cells, which are antigen-presenting cells. These then mature and present the cells in MHC. Then there's an interaction in the lymph node, okay? The T cells are, most of their business is done in lymph nodes. Not in the bloodstream. And here's where you get your signal 1 and your signal 2, your antigen presentation and your co-stimulation. This then allows the T cells to become activated. They're now primed to recognize these specific antigens, and they migrate back into the tumor and can cause cytotoxicity and tumor killing. Okay? The problem is as I said, is there's many steps along the way where other things can either get in the way or turn it off. So you can have lack of migration into there because of the tumor microenvironment. Or what also can happen is these cells can then be shut off. Either they can come back to the lymph node and be shut off by CTLA-4, or they also can be shut off in the tumors themselves because of an interaction that is not totally clearly understood mechanistically what happens, but the tumors then send signals to turn these off. And then there are other cells that can be involved which can suppress these interactions. All right, and this can lead to what's called T-cell exhaustion. And as I said, there are many steps along this way which are trying to augment or increase this pathway. You can have things like radiation, as I said, things that can cause release of more antigen. Ablation, which we use fairly frequently in certain cancers, can also cause tumor killing and release of antigen. This can accelerate and increase the process of presentation. You can have things like vaccines and other adjuvants, which can stimulate immune presentation through dendritic cells. You can have cytokines up here, which can cause more activation and expansion of T cells. And these are all areas of active investigation of ways to try and increase tumor immunotherapy. But what's been interesting is many of them, aside from, like I said, recent developments, have been fairly ineffective. There's a long history of ineffectiveness of vaccine therapies, which is one of the reasons there was a lot of pessimism about tumor immunotherapy for a long time. All right? Again, the analogy is sort of the gas and the brakes and turning on the gas. And this is where checkpoint inhibitors come in and where they've proven to be very dramatically effective. So CTLA-4, as I indicated, is one of the brakes. It's a negative regulator of co-stimulation at the level of the T-cell antigen-presenting cell interaction. So what CTLA-4 does is it comes and it takes those T cells which have been primed to respond and it turns them off. All right, and so the advance was then coming up conceptually and obviously functionally was to come up with an inhibitor of this, and that's what ipilimumab is. Ipilimumab is a CTLA-4 monoclonal antibody. It binds to CTLA-4 and prevents CTLA-4 from turning off activated T cells. And that's what was the first really checkpoint blockade to really sort of usher in the new era of immunotherapy back in 2011. Okay, melanoma was previously sort of a dreaded disease. There's been new targeted therapies that have shown some benefits, but immunotherapy has really been a true breakthrough. And here's this tail on the curve that we were talking about with ipilimumab, and a 22 to 25% 3-year survival, which for melanoma, previously metastatic melanoma, was a death sentence. It's very impressive results. Okay, and then subsequent to that has been the discovery of PD-1 inhibitors. PD-1 inhibitors are also a checkpoint, which again illustrates an important point of the overlapping and complexity of the system. PD-1, PD-L1, PD-1 stands for programmed death and programmed death ligand. It's an apoptosis or a cell death signal. And so this happens in the tumor or in the target. So any target, obviously, like I said, can upregulate PD-L1. It's a way to prevent autoimmunity, as I mentioned. And so PD-1 binds to PD-L1 and turns this T cell off. And this happens at the level of the tumor microenvironment. And so PD-1 inhibitors have been developed and introduced, and these also have been dramatically effective, including in cancers which previously were thought to be resistant to immunotherapy, like lung cancer, as well as melanoma, renal cell carcinoma. And again, seeing these tails on the curve with long-term responders, which is different from chemotherapy. So, we like simple things. We like simple descriptions. Is this like driving a car? Is it like, turning on stepping on the gas and taking the foot off the brakes? In some ways it is, but it's really much more complicated than that. It's really much more like trying to fly a space shuttle. And so, yes, we've had important advances, but there's really, a lot more we need to learn to really control this and take advantage of it. Although the good news is we are starting to learn a lot about all these other factors that are involved in regulating the immune system. So to boil it down, and again, we've been focusing on CD8 T cells as the focus, and I think that's important because that's where really the most dramatic advances have been, and I won't get into all of the other arms of the immune system, although they're being actively studied and ways to increased effector cells and shut-off suppressor cells are under investigation. But we've touched a little bit on checkpoint inhibitors. What checkpoint inhibitors do is they really take the brakes off of CD8 killer cells. CD8s, as I said, are killer cells. CD4s are helper cells, and they allow T cells to really attack cancer and kill cancer cells. And then another important advance, which will probably be, again, in my limited view of potentially another Nobel Prize, would be the development of what's called CAR T cells, or chimeric antigen receptor T cells, which have also been dramatically effective. And so what are CAR T cells? CAR T cells are genetically engineered T cells from each patient. Okay, so you take a patient, you take their T cells, you then transfect them with a lentivirus. Okay, the molecular biology is very complicated. This is a lentivirus similar to HIV. That's why a lot of these patients are seroconvert, although they don't technically have HIV. But anyway, you use this machinery of the lentivirus to engineer the T cell so that it has an antibody recognition sequence on the cell surface, and it has the TCR, the T cell receptor machinery, on the inside. Okay, and what this does is the antibody on the surface can then recognize a surface antigen, and certain tumors have very specific cell surface antigens on them, primarily leukemia and lymphomas, because of the development of blood cells in the body. And so these CAR T cells will then seek out any cells with this surface antigen. Once this receptor engages the antigen, you then activate the T cells, and you lead to all of the same mechanisms of T cell activation and cytotoxicity. And CAR T cells have been dramatically effective in hematologic malignancies because you have good targets. You have very specific and highly expressed targets on all of the leukemia and lymphoma cells. And that's why you've had these very dramatic results, 90 plus complete responders, 90% plus complete responders in leukemia and lymphoma patients. Often those who've even been exposed to numerous prior therapies, they're really at the end of the line. They're heavily pretreated and quite ill. The issue is you can have what's called on-target. They're still recognizing the antigen, but off-tumor effects. And this is particularly relevant in solid tumors where you don't have the same specificity of the expression of the antigen. So CAR T cells really haven't been as impressive in solid tumors. People have tried, right? Colon cancer expresses CEA, GIST tumors express CD117, other things like mesothelioma. People are looking at that, but it hasn't been as effective, in part because normal cells express those same antigens, and you can have what's called antigen loss. So again, these tumors are it's evolution in progress, and so if the cells can get away with getting rid of the antigen, they will. And again, so CAR T cells have to date not been as effective for solid tumors, but dramatically effective in hematological malignancies. Okay, and this is one case with complete eradication of disease this is from Penn, one of their New England Journal papers, where you have just bone marrow being completely eradicated from tumor. I don't know if this projects well, but bulky lymphadenopathy. So, macroscopic disease, not microscopic disease. Macroscopic disease being completely eliminated, often, within weeks to months. All right. So now it's not all a bed of roses. There are potential problems and pitfalls. There are toxicities, okay? This is, I showed you this picture earlier. This is Emily Whitehead. She was the first pediatric ALL, a lymphoblastic leukemia patient treated at Penn with CAR T cells, and now she's a 3-year survivor. But what's sort of interesting, and this gets into kind of, chance and the sociology of medicine, is she almost died. The night she got her CAR T cells, she had a cytokine storm, a SIRS type reaction. She was in the ICU. I forget, if you ever want to watch a great documentary, it's the Ken Burns on Cancer. It's very moving. But she went into this florid sepsis-like syndrome and almost died. And this could have really been the end of CAR therapy if there had been a death with the first patient. But what's interesting is they, have been drawing blood work on all these patients. Her IL-6 levels were through the roof. And Carl June, who was really one of the main inventors of this technology, his daughter has juvenile rheumatoid arthritis, and he was aware that there's a known drug for juvenile rheumatoid arthritis that targets IL-6. So they sort of off protocol, they had to get emergency IRB approval and so forth to give her this IL-6 antagonist, which worked. And they say they report that it the effects were immediate and saved this girl's life, and had hypothetically dramatic implications for the treatment of leukemia and the development of this technology. So interesting, but also can be highly toxic. So now they include the IL-6 antagonist as a standard part of the pre-meds and supportive care for the CAR T-cell therapy. Okay? Toxicity is also important in checkpoint inhibitors, more so the CTLA-4 inhibitors than the PD-1 inhibitors. So CTLA-4 inhibitor is ipilimumab, and the autoimmunity that it can cause can be very dramatic and very severe. And one of the most serious is the colitis. It's almost like a Crohn's-like picture, again, presumably because of the autoimmunity type of reaction. They can get bowel perforations and very, severe peritonitis and so forth. So with ipilimumab, there's a treatment-related death rate of about 1% to 2%, which does give people cause for concern because it can be quite toxic therapy. In addition, as I mentioned, even though this is very encouraging and very significant, there's still a large number of patients who don't have durable response. So, even though we're talking about cures in a minority of patients, there's 75% or more of patients who are not cured. Okay, so 1 in 4, 1 in 5 patients are not cured by these therapies. And that's not trivial when there is a potential death rate, again, more so from ipilimumab than from the PD-1 inhibitors. The PD-1 inhibitors are much less toxic, and that's why you're seeing a significant migration away from ipilimumab in a lot of cases. But also the cost. The cost is as I alluded to earlier, is something that we really don't pay much attention to, and we probably should, because this is probably unsustainable, right? This is especially when you start getting into combination therapies and so forth. These are really high numbers, and it's hard for us as a society potentially to sustain them. All right, but there may be ways, and there seem to be ways to select patients better, to really tailor therapy. One of the big ones is PD-L1 expression in the tumor. So the tumors express PD-L1. That is a sign that the T cells are coming in and being shut off. And PD-L1 expressing tumors respond better to checkpoint blockade, particularly PD-1 and PD-L1 inhibitors. Okay? T-cell infiltration, as we know, is a sign that the body is trying to respond to the tumors, although potentially not very effectively. And then finally, neoantigen load. Okay? And this is also very interesting from sort of an intellectual point of view. This is sort of a cataloging of the number of mutations and the number of neoantigens in different human cancers. And these are predominantly pediatric here at the end, which tend to have a more simple karyotype, a more simple chromosomal configuration. And these here are adult cancers, usually, which are induced by certain carcinogens, such as smoking and lung cancer, sunlight damage and melanoma. Bladder cancer is also smoking. And what's interesting is the tumors with greater neoantigens also respond better to checkpoint blockade, which, again, intuitively seems to make sense because there's more for the immune system to recognize, and the repertoire of T cells is there. They just have been turned off for whatever reason. And this has really been validated in numerous models as an important mechanism of the response. And conversely, some of the less complex, genetically complex, that have fewer neoantigens don't seem to respond as well, some of the pediatric cancers. But you can potentially alter that, and this is where ipilimumab may really find its its place despite the toxicity, because you can turn on the T cells and get them to infiltrate the tumors more with ipilimumab. All right, so what is the future? I think especially for cancer therapy, and as you can imagine, PD-L1 now people are looking at it in everything, right? So not just cancer, but any disease, you name it. People are like, hey, let's try a checkpoint blockade. Maybe there's a connection. But certainly in cancer, this is really going to be the backbone of all cancer therapy, I'm sure, in the future with other treatments. Okay, now just to give you a brief highlight of what we do, since as I said, not everybody responds. There are still barriers even in immune therapy. We look at natural killer cells. And natural killer cells are a subset of lymphocytes. They're different from T cells. They're part of the innate immune system, which is different from the adaptive immune system. And it turns out that NK cells will reject stem cell allografts, and they're very important in sort of regulation of hematopoiesis and bone marrow development. So we've been looking at using NK cells to target cancer stem cells, which are an important subset of cancer subpopulation, which is felt to be responsible for resistance to chemotherapy, resistance to radiation therapy. There are these quiescent cells that are able to seed relapse and metastasis even years after treatment. So we have been looking at human NK cells to target cancer stem cells, and they seem to have a preferential ability to do that. And we validate that cancer stem cells, this sort of population of cells over here, really are the tumor-forming cells in mouse models. These are the cells that are the ones that can cause tumors, whereas the non-cancer stem cells do not have tumor-forming properties. And so that's enabled us to start a clinical trial at the vet school. Actually, Dr. Culp, one of our great collaborators, is here. It's great to see him. So we have a clinical trial for canine osteosarcoma, where we're combining radiation with autologous natural killer cells as a way to try and develop a novel form of immunotherapy. All right, so I'd like to, it's my last slide. I didn't get time to do all the acknowledgments. Dr. Farmer, our lab, all the people, all the residents who've been working with us, and of course my family. So I'd be delighted to answer any questions.
And as you know, I have a special soft spot for immunotherapy, and I had to laugh at when you said the 1998 era when it was all a failure. I thought, oh yeah, that's what I was doing. But it made me think, why aren't we treating every cancer with some kind of, immunotherapeutic intervention? And clearly, your historical presentation about the fact that there must be some level of immune surveillance that happens all the time, which is why not everybody gets cancer all the time. It makes me wonder why isn't it part of our standard?
Well, if you go to the clinicaltrials.gov website, I could have filled up slides and slides and slides and slides of clinical trials of immunotherapy. So it's ongoing. So I think it's just a matter of time.
So what about, who was the sort of crazy guy who had the cancer diet? Was that not an immunotherapy approach? And should we not be thinking about some immune boosting baseline when we're treating cancer patients?
Well, yeah. There's many diets like that. It goes back to Linus Pauling, probably even farther, with his high dose vitamin C. I think there is an immune modulation. We know that obesity now, in this decade, obesity is going to overtake smoking as the number one environmental cause of cancer.
In fact, were those little hamburgers on your slide?
And nobody really knows the sort of mechanism that obesity does it, but a lot of it is felt to alter the immune milieu because it's probably not directly mutagenic as, say, smoking is or UV exposure. So there's definitely exercise has been shown to have important immune modulating properties. And people are proposing RO1s, putting little mice in little, treadmills to model exercise and its effects on immune subsets. So I think it is relevant, although obviously more work needs to be done to really avoid sort of the snake oil approach of it. And then there's been a lot of work with the microbiome. You know, Dr. Ali is a huge proponent of the microbiome, but the microbiome has been shown to modulate response to immunotherapy. Again, probably from altering the immune milieu, and you know, certain microbes have more immune stimulus from sort of the the damage-related proteins and so forth, and can shift the immune equilibrium one way or the other, which can affect immune subsets and the interplay between different cells. So I think definitely.
Questions for Dr. Canter?
Great talk. I thought you did a really great job of making a somewhat difficult to stomach subject very absorbable to the audience.
The card thing helped.
So my question is, I didn't hear a lot about surgery, and do you think that immunotherapy is going to put us out of business, or how are we as surgeons, how can we use it?
Wow, that's a great question. I think, to be honest, I think that immunotherapy may be more of a threat than chemotherapy. You know, people have been talking about chemotherapy replacing surgery for a long time. I mean, dating back to when chemotherapy was introduced 100+ years ago. And as I said, the history of chemotherapy has really been one of sort of, you know, not very encouraging results despite a lot of the hype. Immunotherapy may be different, and that's why personally I'm sort of troubled by, as an aside, that immunotherapy really is being taken over clinically by medical oncology. You know, I mean, immunotherapy was developed almost exclusively by surgeons, and always has been sort of in the domain of surgeons. And so I think it would be very disappointing if surgeons really weren't more actively involved in not only the science, but in the application, the translation of immunotherapy. And I think, you know, if you look, and this would be a great topic to discuss, if you look at a lot of the new technologies and the new medical therapies that have been introduced, it's often surgeons who've done it. ERCP, cardiac catheterization, what? TPN, you took the words out of my mouth. And we've allowed non-surgical practitioners to really take those over and take those away from us, which, you know, is something that I think we, you know, need to really look at ourselves a little bit for allowing that to happen. So I digress. I talk a lot, but as a lot of you probably know. But I do worry about that, and I think we really need to be actively involved. Now, there are regional therapies, there's intratumoral therapies, there's the ways that surgeons can still stay involved, but we really need to stay involved in not only the science, but in the clinical translation. You know, because a lot of the medical oncologists, I mean, I hope none of you are filming me, but they don't know anything about it, and they're giving these drugs and sort of becoming the proponents of it, and I think it's, it's problematic.
Well, the sepsis response, just the SIRS-like response in the early immunotherapy days, I mean, that was the biggest problem, was so similar to taking care of a multi-injured trauma patient.
Yeah.
So the expertise for how to get these patients through those therapies really resided, I think, in patients who grew up in doctors who grew up with surgical training.
Dr. Cook.
Yeah, I want to echo what you said. It's frustrating sitting in tumor board, and I think a lot of it is, we can't really blame ourselves. A lot of it is sort of the priorities of the drug companies and the priorities of the cooperative groups, where they pump these really effective drugs, immunotherapy, for a population where improvement is seen in months, and then the price per patient is so high. Okay, you look at lung cancer, the survival neoadjuvant active trials?
Well, that's a great question, and I certainly am not an expert on that, but that never stopped me. It's multifactorial, right? I mean, that's always the answer. It's multifactorial. But some of it is politics, and the medical oncologists, really have been effective at sort of taking ownership and keeping ownership of that. And some of it, you're right, is the patient population. The stage 4 stage 4 cancer patients. They'll try anything. And that's the best route to get a new drug approved. And there's a lot of economics and things that drive that. But I do think surgeons really should be better about doing clinical trials and about being involved in translational research and clinical trials. Now, there's sort of like a guild mentality to it, and there is some exclusionary effects of it, but we got to try and do better because we should be running these trials and we should be more actively engaged in the science because translational science is really surgeons, and it's really disappointing when a lot of the other specialties look at us as just sort of technicians to hand them tissue. When we, as Dr. Farmer says, understand a lot of the crucial questions and we coordinate a lot of the care. So, it's a great question. I obviously don't have the answers, but I do think we should really be looking at it and trying to do better.
I really do think there's something that's different. We see disease in a much more intimate way. We actually see cancers, and feel cancers that no medical oncologist ever does. The closest they get is, looking at CT scans. But I think there's something that we learn or gives us a different perspective on a variety of diseases by sort of really being in there in a much more intimate way.
Yeah, well, I mean, again, we could talk about this for a long time, and Dr. Cook just walked out, so I'll wrap. But there's mentorship, there's sort of institutional and society sort of support and building up for this kind of approach, and surgeons, I think, we're so persistent about some things, we're so easily kind of affected by barriers in clinical and translational research, which again, maybe it's our priorities, but I think we could do better.
Well, it's a great call for personalized medicine, picking out who's going to be the responder to the CAR therapy, and it's a great reason to keep doing what you're doing. So thank you for a fabulous